Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Healthcare du Jour is brought to you by Carium, the telehealth platform enabling healthcare's digital transformation, helping you care for people within the fabric of their daily lives. Now here's your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Paul Martino, co-founder and Chief Strategy Officer at VillageMD. Welcome, Paul.
Morning.
So, Paul, what I always like to do before getting into the main part of the discussion is to allow my guests a little bit of time to introduce themselves in terms of who they are and what they do. So the floor is yours.
Thanks, Matt. So I started my career in the early 80s, pains me to say that, and I joined what was then Connecticut General Life Insurance Company, today Cigna Corporation. I spent the first 32 years of my career working in various roles within health plans, minus a few errant ideas that I thought I could be, an internet entrepreneur in the late 90s. And I think everybody else thought the same thing. And that didn't go so well for most. But for all practical purposes, I was a health plan executive. The last stop I had was being part of Anthem. So I spent about 7 years working for Anthem, ultimately moving into a role called Senior Vice President of Clinical Strategy and Innovation. And as a non-clinician, it's unusual for a person that's a layperson to have that type of a role. During the time that I was working for Anthem, one of the things that had materially changed, in my opinion, the landscape of where both healthcare financing and care delivery were going to go, was the ultimate approval of the Affordable Care Act. And a lot of things that happen today in this hot topic of value-based care, at-risk care, at-risk primary care, a lot of the underpinnings of that were part of the Affordable Care Act. While I was at Anthem, as I was doing the role, fulfilling the role that I was in, there were a number of things that occurred to me. And in the process of that, I met two other gentlemen who were not part of Anthem. They were essentially running a population health business as part of the publicly traded Accretive Health. So Dr. Clive Fields and Tim Berry were those two gentlemen. And in 2013, we collectively, respectively left our employers and started the company VillageMD. And that's what I've been doing for the last almost now 8 years.
That's a very interesting background. And as you said, you got into the clinical innovation space without a clinical background. So what were some of the challenges in getting into that space? And then also some of the opportunities by being able to bring a non-clinical viewpoint?
I like the question because, Matt, when I was asked by my boss at the time to take on this role, my boss at the time was just to give you a context, Anthem is a 50,000 or so employee company, so it's a big organization, publicly traded. It's 14 state Blues plans, and Anthem has probably pushing now close to $100 billion in revenue. I was one level below the CEO, so there was one person between me and the CEO, and he was a physician. He was trained as an internal medicine physician. And when he invited me to take on this role, I was a little bit surprised. I had been in the company at this point probably 4 or 5 years. He was brand new to the company, felt like he'd been there a weekend. And when he invited me into this role, I said, you do realize that everybody that's had this job before me was a physician, and I'm fairly sure that I would bet anybody after is going to be a physician. And he said, it's an extraordinary time with change in healthcare, and you're going to have plenty of clinicians to support the work. What we need is somebody that has some sense as to where they think the market's going and how we ought to position the company to best be successful and execute in whatever those changes might look like. So that was the opportunity, which I had a great amount of respect for because of the history and legacy of mostly physicians being in that role. Some of the challenges is that, if you're not a physician, and I will share a story with you that will really illustrate the point. If you're not a physician, oftentimes it's hard to get physician and physician leaders to buy into some of the things you're thinking about or some of the hypotheses that you want to test, because after all, you don't really have a clinical background, and how would you know? And so it's a bit of a challenge to get consensus buy-in that this could be an interesting way to think about the future of at-risk care delivery. So those were some of the more meaningful challenges. The other one that comes to mind, when you really want to optimize performance in a risk model, I would say further a clinical risk model. So we'll get into this, not a coding model but really a clinical model. You have to really understand the data and where cost and care happen. Where is the current spend in the system? And because the data seems so intuitively wrong, oftentimes people will say that can't be right. For example, I do this all the time. I've been traveling and meeting with physicians and medical practices in multiple markets over the last week. And yesterday I was doing a whiteboarding session, as we call it, with a group CEO. And I got to the point where I was showing them how the healthcare economics work. And I asked the question, what percentage of the healthcare dollar do you think goes to primary care? And his answer, there are two guys. One guy answered, whatever it is, it's not enough. So I happen to agree. But then the other guy answered 20%. And I said, no, it's shamefully lower than that. It's about 5 to 5.5%. That's a statistic that I use all the time that I picked up when we looked at $100 billion worth of claims at Anthem. And when I first saw the data and saw $5.5 billion being spent on primary care, I too said to the analytics team, that can't be right. You go look at it again. And so getting grounded in the data and what's actually happening stretches the mind a little bit, because some parts of it are counterintuitive.
And kind of with that example, as you said, being able to prove out or demonstrate what's probably a gut feeling or an anecdotal evidence would seem to then arm you with the ability to start identifying and developing ways to drive change.
It's true. That's exactly right. And what I like about the experiences that I had at Anthem that then later translated over, our company, I wouldn't want to go so far as to say we have a lot of people that are pretty good at healthcare economics or math even in our company, because it's both a clinical model, a cost and quality model. And if the underpinnings are the data, then the probability that you're not chasing some other shiny object, so to speak, is pretty good, right? You want to be grounded in the data. When I think about starting VillageMD, when Tim Clive and I first started to talk about it, the original idea was our two companies might joint venture together. That was the original concept. And that seemed perfectly logical given where we were and where they were. When we decided to leave our respective employers and try this, and you approach other people in the industry that you know, a lot of times the reaction is you don't look like three guys that would get together to start a company, because it was not like we were three, Microsoft programmers and we were going to come up with the next big idea in technology development and deployment. We were three really different walks of life. Me being a health plan executive, Clive Fields being a family physician, and for me, he was a healthcare entrepreneur as a provider, and Tim Berry is a bit of a digital technology and healthcare executive / entrepreneur. So you take the three of that profile background, and we think you get a decent outcome because we look at the world very differently. I don't have the ability to look at the world from a clinical model. Would this be good kind of standard of care, patient care? But I sure do have the ability to look at things from a cost point of view and determine, might there be a better way to do some things?
Yeah, and kind of as you described that, the melding together of all those different viewpoints would seem kind of the perfect combination as you're moving into a clinical risk and a value-based care world, because I think you started to allude to it earlier. It's when you move into that world, you're also having to examine a lot more variety of data points, and at the same time thinking about how is this influencing the delivery of care, which would seem like the perfect recipe to bring all those different viewpoints together as the way to come up with an idea that might actually be sold and adopted by all the different sides of the industry.
Yeah. So you raise a couple of really interesting topics, and I want to pull the thread on that a little bit. First, if you are coming at it from different perspectives, you have a more well-rounded global point of view on what might work. On the flip side of that, you might have opposing points of view because you're looking at it from a different lens. So I'll give you an anecdote that hopefully would be easy for the listeners to follow. If I said earlier that the amount of medical spend from a total medical expense point of view that goes to primary care is 5%. And so the lens of a physician, Clive, his job, as he has, kind of performed it over the last, few decades, has been to drive fee-for-service revenue, to minimize the amount of operating expense in his practice, and that would be his take-home income. And so the math on that is one practicing physician is about $500,000 of fee-for-service revenue. They run their clinic with about 65% expense, and their incomes are $200,000 to $225,000. Not a bad income. But if they want to make more money, the way they do it is they see more patients. From a health plan perspective, so that's the perspective from Clive. The perspective from me as a health plan guy is if I'm looking at the total cost of care on a per member per month basis, and let's say it's $400 per member per month, I know that $20 of that is going to primary care. It's that same 5% that I mentioned earlier. And then you want to frame your risk contracts all around that. Here's the portion going to primary care. Here's the total medical expense. And how do we think about it? From a VillageMD perspective, we think that one physician has on average, primary care has on average about 2,000 patients, and that those 2,000 patients on average spend about $5,000 per year per patient. So it's a $10 million business. And so now the question is, if a primary care doctor is $500,000 of fee-for-service revenue, $500,000 over $10 million is the same 5% as the $20 of the $400. So now the question becomes, in the business case of our model, was how do we help physicians understand that $9.5 million of $10 million of expense for their patients is happening outside the four walls of their clinic? And what can we do about that? And so we again, the benefit of the three of us coming together is Clive would see it from a practicing doctor's lens. I would see it from a who's an efficient provider within the 400 of total medical expense. And as VillageMD, we look at it from a population point of view and say, this cohort of patients that is being managed and seen by this provider is a $10 million expense. What's the best way to optimize that with the resources that are available that ultimately lead to the best patient experience, the best quality? And if you get those right, you'll likely have the lowest cost of care.
Yeah, and I suspect this will probably start touching on some of the secret sauce that you're developing, but it's kind of what does that framework look like? How do you start encouraging the primary care physician to, I think as you're saying, better manage and better account for where all the total expenditure is going. And part of that, the basis for that question is, obviously what you're explaining, but then also the data, which seems to support that primary care driven value-based care models are showing the best impact in terms of savings and efficiency.
Mm-hmm. Yeah. So I want to share a parallel, I hope, and then you'll see why. I was reading a book a few years back that was the book about the guy that founded Southwest Airlines, Herb Keller. And there's a part in the book where he talks about, or the book talks about, a guy that was an executive that was working for him. And that guy was tapped by the government of Brazil to go to Brazil and build the Brazilian Airlines. And this guy really wanted to pursue this dream. It's such a unique opportunity. But he was hesitant to tell Herb Keller that he wanted to do this because he had been such a loyal lieutenant for him. So eventually he told him, and Herb Keller said, by all means, you should do this. And so then he said to Keller, do you have any advice for me? And he said, I do. Take care of the crew. The crew takes care of the passengers, and the passengers will take care of the shareholders. For us, take care of the physicians. The physicians will take care of the patients, and the patients will take care of the shareholders. And I draw that parallel because in our world, if you talk with physicians, if you talk with primary care physicians more specifically, they'll tell you the things that they struggle with. They'll tell you that the meaningful use requirements cause them to spend more time in administrative tasks. They'll tell you that the health plans that require that they submit certain documentation increases the need for administrative time. They will tell you that documenting in their electronic medical record requires that they work at night because it's valuable time during the day to see patients, right? So if we can create a better physician lifestyle, which leads to better engagement with a patient, which leads to a better experience for a patient, you get right back to what I said earlier, which is all of that leads to, in my view, high quality, low cost. And so we've been at it for 8 years. Is it working, I guess, is a question. And in my mind, how we know it's working, and this is, you can see this in the press releases that we've done in part with Walgreens. I'm sure there's lots of questions about our relationship with them, but our net promoter scores are over 90. And so to me, that generally will speak to the patient experience. The work that we're doing today is to make sure that we're getting after that physician quality of life, and the results are there for both quality and cost. So we feel like we're on the right path on getting to those 4 objectives.
Yeah, and kind of as you're saying, the ideal is it ends up becoming a self-fulfilling cycle because, as you said, the physicians get back to being happier and less burned out, they're more engaged, which creates better interactions with the patients, which then all just circles back around. And for those of you just joining, I'm talking with Paul Martino from VillageMD, and we've been talking about kind of the development of value-based care and its evolution. And as we were just talking about the ideal goal for the model, as you said, that's from your perspective, you've been working on that for the past 8+ years, specifically at Village, and I think longer in your other lives, but. Where do you see it starting to go as we're, keep transitioning from, the government perspective where CMS keeps rolling out different value-based care models? When do you see a tipping point of, theoretically a majority of practices getting into a majority of reimbursement coming in value-based care? And, kind of how do you see the development continuing to progress?
Yeah. So you're very right in what you said, which is this is something that I've been thinking about, working on, studying for a long, long time. And what I am fascinated by, so I've been at this for almost 40 years. What I've been fascinated by are the changes that I can look back on and say, there's been a lot, they've been material, they've been meaningful, but what I think is in front of us is extraordinary. And I'd like to spend a minute or two on that. First, I'm going to talk about healthcare financing. The changes that are occurring right now, led by CMS and CMMI, are extraordinary. So think about the movement to what I'll call risk contracting with Medicare. Started maybe with Medicare Advantage, which had a predecessor to it, which was Medicare Choice Plus way back when, which is essentially Medicare Advantage plans being subcontractors to Medicare and being on the risk for the premium dollar paid in by CMS. Following that came Pioneer ACOs, and then later Medicare shared savings programs. And then earlier this year, CMMI announced the next iteration, which is called direct contracting entities. So direct contracting goes live on April 1st of next year, and it allows providers to take risk on Medicare fee-for-service beneficiaries. Said another way, as direct contracting becomes more prevalent, ultimately the whole bolus of Medicare patients can be in some form of risk contracts. So this is one big movement. Last week, Medicare, CMMI again, announced the next iteration, which is called the geographic option, which allows providers to be at risk for an entire geography of Medicare patients. And if you think about where patients are attributed today, it's to primary care, who likely couldn't manage this, geography of patients on their own. They would need good specialty care, institutional care, et cetera. So this is healthcare financing at the government level. In the commercial world, the exact same thing is happening, but it's happening a different way. On January 1st of this year, there was something that changed called ICRA, which allows for an employer to make a contribution to an employee monetary contribution and allows them to go buy their own individual or family plan, as they call it, IFP. And the contribution by the employer is tax deductible for the employer. And the money that's received by the employee is tax-free. So the first time this has happened was January 1 of this year. All of this tells me that the financing vehicles for healthcare are underway to push everybody to individual choice, efficiency, and risk. That's where the world's headed. On the provider side, this is financing side. On the provider side, there are incredible macro changes also happening. The one that's happening right now, and I think of it in 3 decades of change. The decade that we're in, some of which was spawned by the Affordable Care Act, is the decade of reorganizing primary care physicians. Again, those are where patients are attributed today. And so you'll see things like health systems determine they maybe no longer can afford to employ primary care, or maybe physicians more broadly. The pandemic helped that, or hurt it, I suppose. You see organizations like Optum being more aggressive, being more acquisitive with primary care providers, right where you are, Matt, in your backyard, right in Worcester, Massachusetts. And so I think there's this reorganization of primary care, the decade we're in. The next decade, and think of it as the organizing decade in the beginning of risk contracting. The next decade, in my mind, is going to be understanding at a global and then granular level utilization and where utilization is occurring. And are we experiencing a lot of unnecessary utilization that maybe we should have and think about intermediate modalities of care before we think about more interventional care? So utilization, people will call it utilization management or something like that. And then lastly, when you have providers that have been reorganized, we've put them into risk models and they truly understand population management and utilization management, the next question will become, should we just take on the whole risk? And you might see integrated providers completely at risk for populations of patients, and think of them maybe as a plan. Now, we've seen this where you've seen health systems jump in and be a plan, but maybe not fully understanding risk and jump out and jump in and jump out. I think this time it's for real, because I think government financing is going to be at risk. Commercial financing is going to be at risk. Consumers are going to demand more, and they're going to be technology enabled. And when you put all that together, I think providers are going to start saying, maybe I should manage the whole dollar.
Yeah, and kind of intuitively that makes sense, because as you said, it's, one, you're seeing the financing pushing in that direction, but also back to your earlier point that if so much of the money is going into all these various places and not with the group who's actually working with and managing the patients, as their sophistication increases, and by they, we're talking about the clinicians. So as the clinicians, sophistication on managing increases, it only makes sense that they would want to keep taking more and more of the responsibilities, which, at least in my mind means, as you said, the risk, because as you keep doing that on, and if you're applying the same standards that the insurance companies would have in terms of actuarial stats and predictive modeling, that just means more money that you're going to be able to make. And it's, really becomes more of a direct connection without an intermediary. So, the direct connection between clinician and patient.
That's right. Well, that's exactly right. With financing not being the driver of where care could or should happen, right? It's the patient and the physician that collaborating in the best interests of overall care and care delivery, health really, and then the financing just supports that. When I was working back at Anthem and I was thinking about the job that I was asked to do, I started to think about and actually had the opportunity to present to our CEO and her executive team my thinking about this. And the line, I tried to simplify it as best as I could. And the line that I used was to say, we should think about compensating those most effectively that are creating the most value. And they look like independent primary care physicians from the data that I've studied. Number two, we should get out of the middle of the patient-physician relationship. We should become an inbound service provider, and we should let them tell us when they need our help. And thirdly, because we have a natural suspicion to, is this the fox watching the hen house? We should move functions that people don't value, like utilization management and case management and disease management and all these things that if you talk to doctors or you talk to consumers don't love, maybe we should create an audit function to just make sure that we're looking at the outliers so that we don't have and allow for engagement and bad behavior. And when you say that inside of a plan, you don't necessarily get a warm reaction. My mind is if you put somebody at risk who's delivering care, you shine the light on the data of where care is from a cost and quality point of view, optimal or suboptimal, and then you insert the patient who is sick and has needs. You're likely going to get a better outcome than what the legacy environment has been, which is mother may I. Like, may I get another bed day for this patient because I think that they are not ready to be home where they don't have as good of a support mechanism as they would if they stayed here, right? This is the model that we're in even today.
Yeah, kind of as you're saying, it's re-putting all the decision-making authority into the ones who are directly interacting with the patients. And, I'm sure not everyone would agree with this statement, but the ones with the better clinical knowledge and the clinical experience, understanding that plans, try to employ, clinicians for some of their what they view as the oversight role. But, as you said, ultimately it is to some degree a level of interference because you're creating a break in the direct chain of interaction between the patient and their actual treating clinician.
Yeah. The one thing that I see as a parallel, and it's a lousy one, I suppose, in some ways. If you go back in time, and I'll use two parallels, right? One was in retail. And when Amazon first came to be, I thought a bunch of people that were running physical assets in retail, and we know who they are today. I think everybody thought there would be no tolerance for online shopping. There would be no tolerance for not seeing the product, touching the product. If it's a garment, wearing the product, right? Trying it on. And I think on the financial side of that, nobody thought Amazon would be allowed to lose money for 20 years before it became what it is today. If I think about a financial parallel, we all, when I first started my first job, I had a pension plan, and there were a bunch of companies that managed pension assets, Travelers, MetLife, Prudential. The 401k came into being through ERISA, and a bunch of those guys didn't believe the change was really going to happen. And today, who are the money managers of 401ks? They don't look like the pension asset managers. In healthcare, the changes that we're talking about, the structural changes, will the plans be the plans that we know today because they believe the change is going to occur and they got to prepare for it? Or will they say, I like it the way it is and I'm just going to hold on to what I know because I know how to operate there? And this massive change the current participants aren't prepared for. Same on the care delivery side. How much institutional capacity do we need in this country? How many hospitals do we need? And you'll hear people say, well, every congressperson's district has a hospital and it's a large employer and we got to keep them going. I don't know, maybe care should be delivered in the home. Maybe it should be delivered by care providers willing to go in the home. Maybe care should be delivered in neighborhoods, communities, more so than in an institution.
Yeah, no, I think those are a lot of very good questions and, a lot of very timely ones. And unfortunately, I don't think we're going to be able to have the time to start diving into any of them because, believe it or not, we're already out of time. I want to thank my guest, Paul Martino, for a great conversation today.
Matt, thanks for having me. I really appreciated being here.
And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.